Thank you very much, ladies and gentlemen, and good morning. I'd like to start by saying thank you very much for this invitation. It's always a pleasure to come to India and especially to Kerala. The one thing about PCOS is that we're not sure where it's coming from, and there's a lot of research going on to try and find out. But what concerns us today really is what's causing the ovulation, maybe the anovulation. If we know the cause of the anovulation, then maybe we'll be able to treat it even better than we are doing today. And the key sentence, I think, of this talk is this one. As you've just heard, in PCOS there are a large number of small antral follicles, and it's the number of these small antral follicles that is actually an independent and a very important factor in the fact that the follicular progress to a dominant follicle does not take place in anovulatory PCOS. So the more follicles, small follicles you have, the worse is likely to be the disturbance in ovulation. Now the problem is, of course, that in PCOS we've got 6 times at least more preantral follicles than we have in the normal ovary. And you can see in this picture here, this is from Helen Mason's group in London. Here are the number of follicles and here are their sizes, and you can see quite distinctly in the yellow line here, these are the numbers of follicles in anovulatory PCOS compared to down here women who have normal ovulation. So there are many, many more small follicles in PCOS. These small follicles all produce anti-Müllerian hormone, AMH. Not the big follicles you can see in the staining here. It's these small antral and preantral follicles that are producing anti-Müllerian hormone. So if they're producing AMH and we measure AMH, then this concentration of AMH in the blood it's a very good indicator of how many of these small follicles we have in the ovary. So if there are more follicles, then naturally you would expect that the AMH concentrations in PCOS will be high. And this is one illustration here. These are the control groups. These are the levels of AMH. And you can see here in PCOS that they are significantly higher than in controls, in hypothalamic amenorrhea, and of course much more than in premature ovarian failure. But not only is the AMH high in PCOS because of the number of follicles, but each individual follicle seems to be producing more AMH than in the normal ovary. Now, whether this is a genetic and an intrinsic property of PCOS, or whether it's due to the excess androgens or insulins, we're not really very sure. But this is a good example you can see here when you compare AMH levels in normal ovaries compared to anovulatory PCOS. 75 times more the concentration in each individual follicle if they have PCOS. So again, we return to this statement that the number of these small follicles is the factor that causes the anovulation in PCOS. And here's an example of the more follicles you have, the more AMH you have, then the more likely you are to have anovulation. Here's a beautiful example from Didier Duayet's group in Lille in France. AMH levels here. If you have PCOS and regular cycles, the AMH will be around 58. If you have PCOS and oligomenorrhea, it's significantly higher than in those with regular cycles. And if you have PCOS and amenorrhea, then the AMH is at its highest. So again, the more follicles, the more AMH, the more likely you are to have anovulation. And this is from our own work, which we've recently submitted. These are in normal women, the AMH levels. Here we have a group of women who have polycystic ovaries that have ovulation. And here, the women with the full-blown PCOS who are anovulatory. And you can see that there's a significant difference according to the level of ovulation. And it's the anovulatory women that have much more AMH. Now, where does this take us? What's actually happening in anovulation is we've lost the influence of FSH to push these follicles forward in order to make a dominant follicle and to ovulate. Now, if we add FSH, whether it's with clomiphene or the FSH injections, then we know very well we can restore this ovulation. So all this suggests that in PCO we have some endogenous inhibition of the action of FSH in women with PCOS. And here we can see the actual levels of FSH, again in our series. This is the FSH in normal women, FSH in women with polycystic ovaries but who ovulate, and FSH levels in women with PCOS who are anovulatory. Now, how does this tie up with AMH? Because AMH has inhibitory actions in the ovary, and it inhibits aromatase and the action of FSH. So the action of FSH, which is there to promote the follicular growth, is counteracted by the anti-Mullerian hormone. And this is what is preventing the normal process of the follicle selection by the reduction in the follicle sensitivity to FSH by the high AMH levels. So, just to repeat, the AMH concentrations are high in PCOS because of the large numbers of small antral follicles, and it is AMH that counteracts this action. So this is what I think is happening. The androgen excess gives you a large number of small antral follicles, producing large amounts of AMH, which suppress the action of FSH. And this is what's leading to the arrest of follicular growth. All these follicles are still producing more androgen, so we have a vicious circle. Also, adding to this is the lack of progesterone. This produces more LH, and this also will increase the amount of androgens, and again we have this circle, this vicious circle of anovulation. What happens if we look at it the other way around? If we reduce the number of these follicles that are producing AMH, then can we restore ovulation? Well, yes, we can. If we destroy some of the ovarian tissue, then we know that normal follicular development will be restored. For example, wedge resection will improve the ovulatory rate, laparoscopic ovarian drilling, and in our own study we saw that after laparoscopy and laparoscopic ovarian drilling, the FSH rises in the those that respond, but it stays at the same level in those who did not respond. So again, it's the FSH that makes the difference. We also know that in women with PCOS who get to the age of 40, then a lot of them will start ovulating again. And this is because, like every other woman, then they're losing their number of follicles. So the follicles goes down, the AMH goes down, the FSH will restore the ovulation. And finally, when we look at the treatment, if we're treating with weight loss, then the lower the AMH at the start, and if it falls, the more likely these women are to ovulate. In the obese women who are given clomiphene citrate, then the response is very much dependent on the AMH. And for metformin, the reason why this is not so successful is if you follow it, it takes a long time for the AMH to fall, and during FSH treatment, then the AMH goes down. So to conclude, the greater the number of small follicles we have in our polycystic ovary, the greater the likelihood of anovulation. And this is because AMH is inhibitory in the ovary, and it's this raised production of AMH by the granulosa cells that contributes to the cessation of follicular development. So the AMH, I think, is involved in the follicular selection, and the high AMH is preventing this selection and the ovulation. Thank you very much.